Welcome, everyone, and thank you for making time to join me this evening to talk about what I know is a very important issue to all of you. It is to me as well, and I feel I am not nearly as close to the matter as all of you are. And so I'm really looking forward to having a discussion about some of the things I'm going to talk to you about today. As Ernst mentioned, this is a two-parter, and in the first part, I'm going to focus on changes to contained in Bill 30 that suggests a move towards privatization of the healthcare system in Alberta. A few things I should mention before I jump into it. The first is that since Bill 30 was introduced and throughout the time that we've seen this sort of rapid changes through legislation to the healthcare system. Really, it's not been just me alone working on these issues. I have worked closely and in collaboration with a colleague of mine, Lauren Hardcastle, who's a professor at the University of Calgary Law School. She has very deep expertise in healthcare law and health systems law. And even in preparing for this presentation, she and I spent quite some time talking through the issues and just trying to address together our understanding of these legislative changes. And that's really important because, as you understand, the government has been very quick with this, and it's been one thing after the other. They've dropped on everyone's lap a massive bill that makes a lot of changes to the healthcare system. And so it's very important that people like me work in collaboration with others like Dr. Hardcastle to try and wrap our heads around all of these changes and how they impact the healthcare system, because we of course want to get it right. So I just want to give a shout out to her. She's been quite instrumental in shaping our common understanding of what's going on here. The second is I need to provide a few caveats. The first is, again, this is an omnibus legislation thrown on our laps very quickly in the midst of what you know to be a very difficult time for physicians in the province and all the controversy and dispute and the situation that the provincial government has placed everyone in. And so the approach I'm taking here is to try to be as factual as possible, to explain the legislation and the parts of it that I understand very well as clearly as possible, but not to speculate too much about where this is going. In part because it's a fast-moving target, and I think many of the impacts of the changes would emerge in time as we start to see the government implement its vision as it contemplates through the changes made in Bill 30. It's also important to understand that when legislation is amended in this manner, it takes some time to understand what everything in legislation means. And because it's legislation, it's expressed at a very high level of generality. It's legislation will never go into the details. And so I think as we go through the legislation, keep in mind that much of what you're going to see happen over the next few years will be things that are based on the government's policies and ideologies that are not apparent to anyone right now. So there'll be things that only the government knows about, and we don't have access to that information. But we can try and at least sort of speculate as to what those policies might be based on what they've expressed in legislation. Legislation is usually very dry, very boring, very limited in the scope of what it explains. I want to keep in mind that our understanding might change or might vary depending on how the government starts to implement policies that they see as an interpretation of legislation. One last thing I should mention is that I've titled this a privatization story for a reason. It's important to understand that the Alberta healthcare system, and indeed the healthcare system in Canada, despite what anyone might have heard about it being a public healthcare system, is in fact has components of it that are private and based on a private system. And I will explain that a little bit more shortly. So this is a privatization story, not the privatization story. It's not as if this is the first time we're seeing privatization happen in Canada or in Alberta. This is just a story. And I think that story is very much informed by this government's philosophies and ideologies and policies that we may not know about. But it is not by any means the start of privatization, and it will most likely not be the end of it. So having said all of that, I'm going to jump into what I plan to talk to you about today. So I plan to take about 30 to 45 minutes and then open it up for questions. Now, Bill 30 is an omnibus legislation that amends a variety of health-related statutes, about 9 of them. I won't be talking about all of those amendments today. For today's talk, I will focus on 2 pieces of legislation that were amended by Bill 30. Next week, I will focus on some other pieces of legislation that were amended by Bill 30, but today the focus is just on the Healthcare Insurance Act and the Health Facilities Act, which was formerly called the Healthcare Protection Act. And that name change happened in Bill 30. I will also focus on the public system essentially, so on services that are publicly insured services, services that are provided or that were provided by physicians and dentists as contemplated in these 2 statutes, which are paid for by the government. So things that are covered by the public insurance system. So I won't be talking about services that are paid for out of pocket by patients or which are covered by systems of private finance, such as private insurance. I think these amendments will ultimately move us in the direction of private finance. And I'll comment a bit about that toward the end of my presentation. But my main focus for today's talk is on public finance and public insured services. So before we get into Bill 30, it's important to understand what the context was before Bill 30, especially the private context. It's important to understand what I mean by when I say that it's a private system and that it's always existed. Bill 30 is not introducing something new. It might be expanding and reshaping something that has always existed. It's not introducing a private system into our healthcare system. So what was the context before then? Now, I'm sure many of you on this webinar will understand this already, so I apologize if I'm explaining to you things that you already know, but I feel it's important for us to have a common understanding from my perspective as to what that context was before Bill 30. So as I've said before, our system is not really in practice public, it's not entirely a public system. It is true that the Canada Health Act and provincial statutes have this requirement where government has to have a publicly administered system which provides publicly insured healthcare services. And I'm sure you're all familiar with that because you all work under that system. However, it's important to note that private finance does play a role in our system, whether in the form of private insurance for certain services or out-of-pocket costs to patients. And private finance plays a role for services that are actually essential services within our healthcare system. The Canadian Institute for Health Information, CAHI, data from CAHI suggests that approximately 30% of health spending is through private finance. Under Alberta law, no private hospitals are allowed. You can't establish a private hospital in Alberta, but there is private delivery of healthcare in Alberta and throughout Canada. So even though the system is based on, to a large extent on public insurance and a publicly administered system by the government, delivery is private in a lot of ways. So as you know, the individual physicians who deliver services under a fee-for-service basis, that can be considered a form of private delivery. But you also have professional corporations who deliver healthcare as well. So the way to think of our system is that it's publicly administered, but not exclusively publicly delivered. That's really important. So we've always had some form of privatization. So I think when we say, Bill 30 is privatizing the system, we really need to sort of be careful about that, because what it's doing is not privatizing the system so much as it's expanding and changing the ways in which private delivery happens. But we've always had private delivery in the system. Now, the Canada Health Act is implemented in Alberta, and that implementation constrains our system of private delivery and private finance in a lot of ways. Most of you will be familiar with this already because, again, you work under the system. But as you know, you cannot use private finance for publicly insured services. So services that are publicly insured cannot be paid for out of pocket by patients. You can't ask them to pay out of pocket, and you can't bill to private insurance for those same services. As you know, there can be no double dipping, which means that if you're a physician, you have to opt into physicians are opted into the public system. And if you want to maintain a practice in the private system, you have to opt out of the public system. To the best of my knowledge, I believe nearly every physician in Alberta, maybe except one person, is opted into the system. You can't have it both ways, essentially. You're either in the public or the private system. Some provinces actually prevent physicians from practicing in the private system at all, but Alberta does give you that option. You also know that you cannot charge patients user fees if you're providing publicly insured services. And of course, there's no extra billing allowed, which means that you cannot charge patients more than the public tariff, more than what you're billing the public system for the services that are provided. So this is the framework, sort of a basic framework of how things operated before Bill 30. Now, in the surgery context, because that's another context we're going to be talking about, you may also know that the government does pay for surgical services as well. There's surgical services that are covered by the public insurance system. Those surgical services under the Healthcare Protection Act, or what is now known as the Health Facilities Act, are provided in public hospitals or in surgical facilities that are designated as such under Division 1 of the Healthcare Protection Act, or what is now known as the Health Facilities Act. So these designated surgical facilities can and are indeed oftentimes private. And they're designated to provide insured surgical services. So they bill the government. So again, this is not new. It was there before. And under the Health Facilities Act as well, you have facilities that are designated to provide uninsured inpatient surgical services. These facilities, I suppose the question is, why have them under legislation? I think it's because the government wants to sort of keep an eye on them and make sure they're accredited and they maintain certain kinds of standards. So the designation process for this works differently from the Division 1 designation. These Division 2 surgical facilities do not provide insured surgical services, but they provide services that are not covered by the system of public insurance. Again, this existed before Bill 30. So what did Bill 30 change? What changes exist under Bill 30? So the first thing we should note right off the bat is that the framework for public insurance and public administration remains largely unchanged under Bill 30. Bill 30 has not introduced a system of private finance or changed how the public finance and public insurance system works. That is largely unchanged. As I said before, maybe this is coming, but it's not there now. The main focus of Bill 30 includes changes that expand private delivery options. So this is really key. It expands options for private delivery beyond what it was before, beyond what I just told you about. And we're going to look into how that, what those changes are. The second thing it does, and I think this will be of interest to many people on this webinar, is that it alters the exclusive billing relationship between the government and physicians and dentists. Prior to Bill 30, only physicians and dentists really could bill the government on a fee-for-service basis. And I won't tell anyone on this call about how, that has played out recently. And what Bill 30 does do is alter this exclusive billing relationship and create new forms of financial relationships and billing relationships between the government and other types of entities. So let's look at one of the first key changes. Bill 30 introduces a new type of provider or biller that can bill the government. So again, it alters this exclusive billing relationship between the government and physicians and dentists by allowing a new form of provider or biller to bill the government for services. So who is this new entity, person, biller that Bill 30 provides for? It creates a new category of provider or biller called the person. Now, as a lawyer, this is it made me chuckle. It's very interesting. It's really, if you have to think about how people draft legislation, sometimes this is one that is quite devious, I think. So who is a person? I use this meme because typically when you want to draft legislation, you can say this legislation applies to physicians, dentists, corporations, whatever. But the way this is done is they say, look, a person is now a new type of provider or biller. And in defining a person, they define by excluding certain categories from the definition of person. So if you look in the amendments, what you're going to find is not the definition of a person, but who is actually not a person. So the definition is that a person is not a professional corporation or an individual. So I hate to tell you this, but Bill 30 does not consider doctors and professional corporations to be persons for the purposes of this change. So by excluding professional corporations and individuals, I think what they're doing in effect is admitting other kinds of corporations as new providers or billers. So if you're a corporation other than a professional corporation, you can bill the government to provide services that are insured by the government. So for example, private corporations, but also public corporations could, but private corporations could, in fact, bill the government now for services. So this is, I think, the major change in the legislation is introducing a new category of provider or biller. So I'm going to say a person, but you now know what a person means. It means not you. So a person can enter into a financial or billing arrangement with the government to provide insured services. I have said financial or billing arrangement because, and we'll get into this a little bit down the line, because in some situations, that person is not allowed to bill on a fee-for-service basis. The person has to actually enter into a financial arrangement that is not a fee-for-service type arrangement. And I will explain this when I come to the surgery context. Now, other than this change, persons, by which I suppose we mean corporations now, operate on essentially the same conditions that existed prior to Bill 30. So much like professional corporations and individual physicians and dentists, persons can't charge user fees, they can't do extra billing, they can't double dip. All of those conditions remain intact. So Bill 30, in effect, changes the system of private delivery by expanding it to create a new type of provider. And it also changes the exclusive billing relationship, but it doesn't change anything else, really. Persons can also only employ opted-in doctors. So this is, I think, very important. What this means is that the only source of personnel or human resources for, say, a corporation in this space is doctors who are opted into the system. So it means that the public system essentially, and of course, professional corporations will now be competing for human resources with corporations that start to operate in this space. Now, the government pays the person, the private corporation, not the doctor who provides the service. So say, for example, we have a corporation, say we have, let's call the corporation TELUS. Let's say that corporation, well, let's not call it TELUS, I don't want to get sued. So let's call it Corporation A. Let's say Corporation A were to enter into a financial arrangement, a billing arrangement with the government.
Getting a little bit of, there's a kind of a brownish stain right here, and right, it's sort of hard to see, but I wonder if we could do a little bit more stain removal to see if we can get that out. I know it's hard to see.
Sorry, I'm hearing something about stain removal. I think that's somebody else on the line. Can we mute that? Oh, thank you. So, right. So the government pays the corporation, the person, not the doctor who is employed by the corporation to provide a service. So that raises a question for me, which I'm happy to park for now. What if the corporation becomes insolvent? Say you're working as a physician for a corporation, and that corporation has a financial arrangement with the government, and you provided some services and the corporation becomes insolvent. You can't bill the government for those services you provided. The minute you start to work for that corporation, that relationship, that billing relationship is no longer there. And so that's something we can talk about a bit more. I thought it was interesting as we're looking through the legislation. Now, the other change in Bill 30 is not really a change. I call it a change, but it's not really a change. And this is in the surgical context. They have rebranded surgical facilities. Nothing about what I'm going to describe to you right now is new, really. Instead, it's a rebranding. As I explained before, under the legislation before Bill 30 was introduced, insured surgical services could be provided by public hospitals or by Division I designated facilities. Under the changes, it rebrands surgical facilities other than public hospitals as something called chartered surgical facilities. Now, chartered surgical facilities include both Division I and Division II designated facilities. So it's just now a new name for something that existed. So this now means, it could mean a facility that's designated to provide insured surgeries, or a facility that is designated to provide uninsured inpatient surgical services. They've just given it a common name. Now, I spent some time thinking about why they did this. It is possible that it's just one of those let's clean up the legislation type things, have names that make more sense to us. I, for one, am somebody who's quite suspicious of this government's motives, so I'm not entirely sure that I find it compelling to believe that there's no reason behind this, but I don't know what the reason is, and I have searched and I've spoken to colleagues about this. I don't know why they will rebrand it this way, but it doesn't seem to be any real, the change doesn't really seem to have any sort of practical effect. So why have they rebranded it? I'll be curious if anyone knows why they've rebranded it, and anyone can share, because I don't know. Now, these surgical facilities can provide publicly insured surgical services or uninsured services depending on designation. So I suppose what you're going to see is, say you have, you're interested in having one of these facilities, you can apply to the government saying, I want to open a publicly insured I want to open a charter surgical facility to provide insured surgical services. And then when you go through the process for doing that and submit all the documents, they will designate you as such. So I suppose when you get your letter of designation, it'll be something along the lines of, you are a charter surgical facility designated under Division 1. Or you could be a chartered surgical facility designated under Division 2. Again, this is not a new thing. You can't be, obviously private hospitals are banned in the province. So the charter surgical facility cannot be a private hospital. It must be accredited by CPSA. This is not new. It cannot perform surgeries designated as major by CPSA bylaws or by government regulation. Again, this is not new. Nothing here is new. It can, to provide insured surgical services, it has to do so with opted-in physicians. Again, nothing new about that. So this seems like just a mere rebranding, and I can't quite put my finger on why it's been rebranded. Now, what that means in effect is that a charter surgical facility can be operated by an accredited individual, by an accredited professional corporation, or by an accredited corporation. Again, that's not a new thing. Before the legislation, before Bill 30, this was essentially the case. Now, I don't know for a fact how many surgical facilities in the province are run by private corporations, but that was something that could happen under the legislation before Bill 30. And I suppose it can happen now still, although I'm not quite sure why they had to rebrand it. But there's a change that is important to note. If the charter surgical facility is operated by an accredited corporation, it cannot contract with the government on a fee-for-service basis. Instead, it has to enter into a financial arrangement with the government that is not fee-for-service. This is new. This is the only thing that is new. It cannot charge patients for what is called facility services, so things like nursing and lab services. This is not new. No user fees. You can't charge user fees. It can't charge fees for priority access. And it can charge patients for enhanced services, but it cannot grant patients preferential access because they bought enhanced services. Now, enhanced services is something I think is interesting to watch. It happens under the current system. In the system that existed before Bill 30, it'll be interesting to watch how it happens. I have some concerns about enhanced services, especially in a situation where you're offering enhanced services that are of lower quality compared to what the public system offers. So in summary, in the surgical context, there really isn't much that Bill 30 brings to the table other than a name change, but also this idea that if you're an accredited corporation providing surgical services, a fee for service is not what the government wants to pursue here, but rather you have to enter into a contract with the government for a different kind of alternative payment arrangement. Okay, what's the rationale for all of these changes? Based on what the government has put out there, the three things that we've seen is to reduce surgical wait times, reduce costs, and improve quality of care. So I'm going to very quickly go over these three rationales or reasons and sort of share my thoughts on whether the changes to Bill 30 would achieve them. But first, let me summarize what I've told you about Bill 30. Bill 30 expands private delivery options and brings in the possibility of corporations, private corporations other than professional corporations operating in that space. It doesn't do much in the surgical context other than to say that corporations could play, and in playing, they can set up alternative payment arrangements with the government that are not fee for service. Okay, I don't have to tell anyone in this room, wait times are a problem. You know, if you go to CAI data, you will note that it's not getting better. So I think the government is right to say they need to deal with wait times. The issue is this the best way to deal with wait times? So will private delivery shorten surgical wait times with the expansion that I've just talked about, shorten surgical wait times? My take on this, and I'm curious to hear your views on this during the Q&A, is most likely not, at least not by itself. The weight of the evidence suggests that simply expanding options for private delivery will not do the job. You have to make improvements to the public system. You have to, there has to be some recruitment that is done. There's much more systematic things that can be done other than just saying we're expanding options for private delivery. And I think the way the government has gone about it, it will not achieve what the government is looking for without hurting the public system. So I think there might be some gains, but those gains there'll be corresponding losses to the public system. So let me just highlight a few of what I think might be those losses or pain points to the public system. So I think increasing surgical capacity, for example, requires additional health professional hours. So if we're thinking about surgery context, if the government is planning to reduce surgical wait times, they're going to need people to do those surgeries. So what are the options for recruitment? You could recruit new staff to Alberta. I don't know if that's possible in the current environment. I don't know any doctor who wants to come to Alberta, but maybe you guys know and can tell me about people who are waiting in the wings to come to Alberta. And I'll just leave that there. So I think that's going to be very challenging for the government in the new environment. They could recruit from the public system. So they could offer all kinds of incentives. And I think there's some incentives that will just come built in. So, one thing we know about corporations when they get involved is that they tend to work for shareholder value, not necessarily for the benefit of patients, especially if that doesn't jive with shareholder value. We know that they will be looking to skim off the less complex cases so they can do as many of this as possible. And they might actually offer incentives like better hours. Physicians might be able to sort of do more of these surgeries. Surgeons might be able to do more of these surgeries and get paid more without having to, sort of exhaust themselves the way they would in the public system. And so that might incentivize many surgeons to move over to the private system, thus depleting the public system. But they also go with, additional, not just surgeons, but anesthesiologists, nurses. So I suspect that there'll be a loss of human resources to the public system if they start to recruit from the public system. So the point here is you're going to need an increase in surgical capacity to deliver on this promise of shortening surgical wait times. So where are you going to get staff from is the question. All the evidence we have suggests that the private system, again, as I said before, will be skimming up the least complex cases. I don't see, how it will be to their interest to take on more complex cases, but also the fact that I think they might not be equipped in terms of facilities to handle these more complex cases. And so what might end up happening is that they skim off the least complex cases, which will then leave the public system with a backlog of complex cases, and then increase wait times in the public system, especially if you add in the element of loss of human resources. So treating more complex cases with fewer staff will likely drive up wait times in the public system. And there's good evidence that this has happened in other systems that have attempted this. And I know the government likes to cite the Saskatchewan Surgical Initiative, but as we all know, that didn't work just off of creating a system to soak up the surgeries. In fact, when that wasn't working, they had to turn to other types of initiatives to try and have an impact on the wait times issue. Will private delivery reduce costs? Again, my report card on this, my verdict on this is most likely not. Most likely not because, again, I think when you have a system that's working for shareholder value, and for return and for getting a return for investors, that's going to be their focus, not necessarily to try and do things that are beneficial to patients or to the system. So I think the cost to the system is likely to be more. So and when I think of cost to Albertans, and the cost to the healthcare system is likely to be more because of this skimming phenomenon that I've described. So if we assume that the cost per surgery is going to be the same, regardless of where the surgery is performed, whether it's performed in the public system or private system, then you can see a situation where the system is paying more because the private system is skimming off the more the less complex surgeries. And if a surgery is a surgery and we're paying the same rate, they're going to be able to sort of impose a lot of costs on the system by skimming off those less complex surgeries and leaving the more complex ones for the public system. Now, this is not the first time that we've seen, this argument about cost come up and how it's been shown to fail. A previous experiment with privatization in Alberta, for example, illustrates that private delivery will not generate any cost saving. Between 2004 and 2008, the Calgary Health Region contracted with the Health Resources Center, which was a private outfit, to pay them at least $30.6 million to perform orthopedic procedures on publicly insured patients. The per case rate paid to HRC, which built in a 10% margin for profit, was higher than in the public system, despite the fact that HRC took on the less complex cases and had lower overhead costs than public hospitals. It cost them about $486 more per hip and knee replacement, $515 more for, it cost the system more, about $400 more for hip and knee replacement to do it through HRC. It cost the system $515 more for shoulder replacement and over nearly $2,000 more for foot and ankle surgery than in the public system. So we've seen this, it's happened before, and it's likely to happen again. And when the company that owned HRC ran into financial difficulty, Alberta Health Services swooped in and bailed them out at considerable cost to taxpayers. So, that's like a double hit. So in effect, the system itself was not beneficial, did not benefit from moving these surgeries to the private, to HRC. But when HRC ran into trouble, who was there to bail it out? The public system. So I don't think this, based on evidence of what happened before, is going to be any different now, or at least the government hasn't answered the question about what will be different this time. So because they need to deliver return to investors, they will build in a margin for profit, which will drive up costs and make it generally more expensive to do these surgeries in the private system than in the public system. Okay, lastly, will private delivery improve quality of care? Again, I don't think so. I don't think, for this, I'm just going to rely on all the studies that we've looked at that show that for-profit delivery leads to poorer outcomes. We have a paper under review right now, Dr. Hardcastle and myself, where we review the evidence, and I'm happy to share that with everyone. But let me just say that if you look at all the evidence, if you review all the evidence, there's just no indication that this is going to lead to better outcomes. In part because these corporations, if they get involved, because they are beholden to their shareholders, I don't see how they're going to place patient care and quality of care above a profit. The only way, so what I'm suggesting is that quality of care is basically going to depend on how much profit they're making and their view of profit. If those two things are at loggerheads or if they're inconsistent with one another, then they're simply not going to favor good quality care over making profits. And this is the experience in countries where this has been tried. And again, like I said, the evidence suggests that it's going to lead to poorer outcomes. One question I do have, though, is, and I'd like for someone from the CPSA to provide an answer to this, is we know that physicians, individual physicians, surgeons, and dentists are subject to professional standards. These corporations are not, to the best of my understanding, subject to professional standards. So when they start operating, they will have to be accredited, but how do we apply professional standards to them? We can apply it to the physicians who work and surgeons who work for them, but they don't have their own standards that they have to meet that is compelled by the professional colleges. So I think that needs to be sort of sorted out or resolved in some way, because if they don't have to meet the same standards, then they can, in fact, decide not to meet those standards, and that might actually lead to lowering the quality of care as well. All right. Just take a couple of minutes before I open it up for Q&A to talk about the road to private finance. As I said, Bill 30 maintains all the limits on private finance. It doesn't change much in that arena. This is just a story of expanding options for private delivery and a story of ending the exclusive billing relationship with physicians and surgeons and dentists. But it doesn't do much on private finance. However, we know that this government is minded to go in that direction. And how do we know this? Well, first thing I should say is that, as many of you know, private finance has come under a lot of legal challenges in recent years. There's the Cambie Surgeries case in BC, which will wind its way through the courts and will end up at the Supreme Court of Canada. And in that case, the Cambie Surgeries is challenging BC laws that ban extra billing, that ban double dipping, and that ban private finance. And depending on the outcome of that case, so let's say they're successful, and that is deemed to be a violation of the Constitution, then what you might see is that our government will be emboldened to explore private finance. I don't think it's a secret that they actually are fans of private finance. So I think that's something to watch out for. But also, the minute corporations start to operate in this space, and this is something that we've been trying to wrap our heads around, Dr. Hardcastle and myself, is if they start to operate in this space, are they going to be content with just, I don't know, setting up private clinics or private surgical facilities? Is this what really the play is? If we look at other countries and the big players in other countries, are they going to move to Alberta for just that? So they might want the government to sweeten the pot a little bit to incentivize participation in the system. And there's two ways I think this is going to happen. I think, if we start to see uniformity in terms of these changes among provinces. So, if Saskatchewan and Manitoba, for example, were to go in this direction as well, that might create a big enough market for these corporations to play in. But also the other way this might happen is that once they're in here, they might go, well, this is not enough. So let's sweeten the pot by going in the direction of private finance so we can have more payers and more things that we can do. And who knows, maybe all of that is in the horizon, but it's something to watch out for as well. But we also know that it's no secret that the UCP and this government through their Fair Deal panel have stated a preference for changing the system and for providing for two-tier healthcare. So I think, it's just a matter of time. This might be the first step, but I certainly don't think is the last we're going to hear about this. So that's all I have in terms of a presentation. Thank you for listening. I hope that was instructive in some sense, but thank you for listening.